the use of the new ultrasonic AC tips to prepare and finish the access cavity. Is a total of 5 tips, 5 different tips. Each one has its own application. They are very efficient, very safe, and very resistant. Here are the 5 tips, and they can be connected to any ultrasonic unit. The one I use is the one from Woodpecker D600. Now, what do we expect from ultrasonic tips? Each one should have its own application. That's why they have different shapes. We want them to be efficient, to be resistant to breakage, and I never broke any of these. They should be easy to be used, long-lasting, and not too expensive. Let's see each one of them. This is the number 1, to finish the access cavity walls. This is the same tip at high magnification, and what we can see here is what make these tips very efficient is not the diamond coating, but they are the grooves or sort of blades. They are present on the working surface. The tip number 1, however, has a smooth tip, which means that at the end, at the tip number 1, is smooth with no blades, no grooves, so it's not cutting. Of course, has the water port for irrigation, but most of the time can be used at maximum power without any irrigation. The irrigation is open from time to time to clean the operative field and to clean the grooves, the blades, from all the debris. The AC tip number 1 is designed with a non-cutting tip of less than 1 millimeter. That means that in cases where the roof and the floor of the pulp chamber are almost in contact, we can still put the non-cutting tip in contact with the floor and still cut the remaining particle of the roof with the surrounding grooves or blades. Let's see some clinical case. Here the access cavity has been performed using a high-speed burr until I was high-speed diamond burr until I was almost at the end of the roof of the floor chamber, of the pulp chamber. Now what I find is a lot of composite on top of the floor, and I am removing all the composite with the tip number 3 that we will discuss later, which has a sharp tip, which makes the tip very efficient and very aggressive to remove all the composite. This could be done with a high-speed diamond burr, but it's quite dangerous because with a spray of water and the head of the handpiece, the visibility is very, very poor. On the other hand, with the ultrasonic tip, we have a wonderful control of what the tip is doing in every single second, removing the composite until we are at the orifice of some root canal. Here we can see the carapace in one canal. And now look at the big piece of composite completely removed with an ultrasonic tip. And this is done, as I said at the beginning, with the tip number 3. Now irrigation to clean the grooves, the blades of the tip, and the operative field. And this is now the floor where we can finish and remove the remaining particles of the roof of the pulp chamber and we can start our retreatment. So now with the tip number 1, which is smooth at the very end, we can even touch the floor without making any damage. And then with the side, we remove the remaining particle of the roof of the pulp chamber. Still working dry, very delicate. It's like brushing without pushing, but just brushing the dentin walls with the ultrasonic tip, and you don't see any burning of the ultrasonic tip, which is, as I said, is working at the maximum power with no irrigation. So it doesn't develop so much heat and is very, very safe. We continue until all the remaining particles of the roof are completely removed. Then with the tip number 3, we can even start the retreatment, so that with the heat that we develop on the ultrasonic tip, we can soften the carapace and start the removal in the coronal portion of the canal. Then, of course, we will continue with other method to remove the carapace deeper inside the canal. Now let's see the use of the tip number 2, which has been specifically designed to facilitate the finding of the MB2 canal. The tip number 2, ED52 actually, is similar to the number 1, with the exception that it is a little bit thinner and has the blade also at the very end, at the tip. Now with the micro opener, I'm starting to negotiate the MB2 canal, and now with the same tip, the number 2, I keep removing the dentin which is hiding the orifice of the MB2 canal. And here it is, after it has been cleanly shaped, of course. Let's see now in detail the AC tip number AD52, which has, as I already said, has been specifically designed to find the MB2 canal. This is the tip at higher magnification, and here we can see that the blades are not only on the side but also at the very end of the ultrasonic tip. We know from the literature and from this article from John Stropko that the MB2 canal can be negotiated in vivo in 93% of the cases of the first molars and 60.4% in the second molar, which means it's almost always there. Sometimes the MB1 and MB2, they join together, like on top. Some other times they are completely independent, and so to miss one of them, to miss the MB2, can be the reason of the endodontic failure. In this drawing, I here represent the floor of the pulp chamber, and this is supposed to be the mesial wall of the access cavity. It happens many times that the dentist introduce a small file, but he can penetrate for 2 millimeters or maybe 3, but not more, and then it doesn't make any other progress. And many times when I ask why you think that the instrument doesn't make any progress, many times the answer I can get is, well, I think the canal is calcified. No, the canal cannot be negotiable at the beginning and then become calcified, because it's exactly the opposite. It is calcified first, and then when you remove the calcification, now the canal becomes negotiable. Remember that the calcification, they always progress in the coronal to apical direction. The reason why the instrument doesn't make any progress after 2 or 3 millimeters is because it has a very sharp curvature at the very beginning, and that's why it doesn't make any progress. And this is because the mesial wall of the access cavity, it doesn't meet the floor with the 90 degrees angle, but with an acute angle. And this is the reason why we have a very sharp curvature at the very beginning of the MB2 canal. So with the tip number 2, we work both with the tip to open more and better the groove that goes from MB1 in a parallel direction where the orifice of MB2 is present, and we work also on the side to remove this gray portion of the drawing, which is the protrusion of dentin from the mesial wall towards the access cavity. See, this is what it's doing. And now, if we introduce the instrument in the same MB2 orifice, now we have the straight line access, and now the entire root canal can be very easily negotiated. This is a typical example of an upper molar with the MB1 and MB2 canal. And I want you to notice that the MB2 orifice, many times or sometimes, however, it looks smaller than the orifice of the MB1. And the reason is that the two canals are joining together. Of course, in a sequence in upper molar, I suggest, and this is what I do every single time, to prepare the palatal first, the distobuccal, and then the mesiobuccal. And when I say prepare start to finish, ready to fit the cone. So when I start to negotiate the MB2 canal, I actually introduce and fit a gutta-percha point in the MB1, and then I move the file in MB2, and then remove the gutta-percha from MB1, and check if there is any impression, any groove, an impression of the file in the gutta-percha. That means that the two canals were joining together, so I know that they join together, and I can check also how far from the common apex they join together. The working length of the MB2 canal will be the point where they join, so the preparation will be a few millimeters shorter. I develop a shorter taper, and this is the reason why the orifice is also smaller. Of course, we have to be prepared to all kind of variation, where we can have MB1, MB2, and MB3, MB1, MB2, and then a groove. Let's be curious. At the end of that groove, there is MB3, and then MB2 and MB3, they join together, so we only see in the postoperative film two canals. And this is the same molar. This is not an extracted tooth. We are working on a patient. So this is MB1, MB2, and now let's be curious, because I see a groove and a little orifice in the palatal direction. This is the orifice of the MB3. So now I introduce a gutta-percha point in the already prepared MB2 canal, and the K file in the other orifice of the MB3. Now I move and I remove the file, remove the gutta-percha point, and now I check if there is any kind of impression, and there is a groove several millimeters away from the working length. From here, I see a long groove. That means that they join together in a quite coronal portion. In this other case, we have MB1, MB2, and MB3, each one with an independent foramen, 1, 2, and 3. And here again, if I miss one of them, then I have an endodontic failure. Why it is so important to know as soon as possible if the MB2 and MB1 are joining together? Because as we can see in this cross-section of the mesiobuccal root, the amount of dentin that I have around MB2 is not the same amount that I have around MB1, because the root is becoming thinner and thinner in a parallel direction. That means that if I can remove less dentin, and I can do it because I know they join together, it is very safe, and I avoid excessive enlargement of the MB2 canal with a high risk of a strip perforation. If I don't check the fact and I don't realize that the two canals are joining together, but they join together with a very acute angle in the very last few millimeters, it's not a big mistake to go to the same working length coming from MB1 or from MB2. But if they join like this with a 90 degrees angle, to pretend to go from MB2 to the same working length of MB1 will be extremely difficult, almost impossible, with a high risk of making a straight perforation, or to make transportation of the foramen, if I can arrive to the foramen, or to break the instrument, because the instrument is making a curvature to the left, and then we ask the instrument to make a 90 degrees angle curvature to the right. The instrument can break very easily. So this is another case where the canal join together. You can see a tunnel in the gutta-percha point, so we know exactly where they join together and how far from the common apex, about 4.5 millimeters, they have a common apex. Here the same, different cases. So this is in higher magnification the tip number 2, specific design to facilitate the finding of the MB2 canal. This is the drawing. It has the water port like any other tip. And now in another vital case, in another tooth in the mouth, you see the tip working with the tip, opening the groove, and now it's working on the side to remove the protrusion of the dentin of the mesial wall of the access cavity in order to have a straight line access. Irrigation to remove the debris from the access cavity and from the tip. Suction. Here I expect the orifice of MB2 canal. This is the micro opener. It's a K file held by a plastic handle. Now I introduce an 08 K file in the MB2 canal. As you can see, the palatal, the distal, and the mesobuccal are already clean and shaped, ready to fit the cone. So when I start to negotiate the MB2 canal, before doing any shaping of the canal, I introduce a gutta-percha point in the MB1 to the working length, like this. And now I move a little the K file up and down in the MB2 canal. Then I remove the file. Then I remove the gutta-percha point, not the opposite. And now I check for any kind of impression. And here one more time we have a groove starting from here. So the working length will be this much shorter for the MB2 canal. So this is just after negotiation. And this is after has been cleanly shaped. One more time, because the two canals were joining together, you see that the orifice of MB2 looks smaller than the orifice of MB1. Let's see now another application of the tip number 2. Here is a case where I was treating this lower left second molar. I was treating a very good friend of mine, and I got distracted, and I just found the distal and one mesial, and I thought there was no other canal. But when I did the compaction of the worn gutta-percha in the mesial, when I saw the X-ray, I saw this material entering somewhere which is not the lateral canal, because lateral canal is such a coronal portion of the canal, they leave the main canal with a 90 degrees angle, not with an acute angle. That means that here I was lucky enough to push some material in the canal that I was completely missing. And I was missing because I didn't see the orifice of the canal. This is the only mesial canal. Of course, this image is through the mirror. So this is the mesial and is the mesiobuccal. And I was missing the mesiolingual, which is underneath this protrusion of dentin here. This dentin has to be removed, and the best method to remove that dentin is the use of the tip number 2. Pretty thin, very efficient, which is now working with the tip having the blades, which makes the tip efficient enough to remove the amount of dentin. Now, when I remove the dentin, if I see some pink material, that means that that pink material, which is right there, is the material that I, without knowing, I pushed, here it is, in the mist canal. This is the micro opener, and now I can start to negotiate with the sodium perchloride and my K file. I am at the working length. This is the sodium perchloride making many bubbles. It means it's digesting the pulp tissue and the remaining tissue that I forgot in the mesiolingual canal. So this is after the canal has been clean and shaped. Of course, I didn't touch the other gutta-percha because I was the one who made the cleaning and shaping duration of the other two canals. This is the confit. The canal had an independent foramen, and this is the immediate post-op. Let's see now more in detail the use of the tip number 3, which is ideal to find calcified canal, removing calcification, and it's also a very good tip to remove fiber glass of carbon fiber post. This is the tip with a very sharp tip. Now in the kit, I asked woodpecker to put 2 of this tip number 3. So the kit has a total of 6 ultrasonic tips, because not only the 5 that I'm describing now, but the dentist will find 2 tips of the number 3. And the reason is because this tip, it will not stay sharp for a very long time, and these are the tips, the number 3, that needs more often to be replaced because the tip become used and smooth. But even though it is smooth and not so aggressive, can still be used to remove composite, to remove the coronal portion calcification, to start a retreatment, removing gutta-percha in the coronal portion of the canal. So don't throw it away because it has millions of applications, even though it is not so sharp anymore. This is the tip, of course, with a water port for irrigation, and this is the typical case where I use this tip. This is a young lady referred to me by a periodontist friend of mine from north of Italy, and the lady had an accident several years before, and because of the accident, the pulp became inflamed and then calcified and then became necrotic. Now developed symptoms, so she went to a dentist. Now the dentist made several mistakes, and I know because he wrote in the stationery everything he did. First of all, he didn't use any rubber dam, because in his intraoperative X-ray I didn't see any shadow of the rubber dam clamp. Second, he gave anesthesia, and there was no reason to give anesthesia in a patient treating a necrotic tooth. Then the other mistake, he went too much to the distal, but more important, which is the typical mistake, too much to the buccal. So he made 2 perforations in the cervical area. And then, because he knew that the perforations today are treated with MTA, he sealed the perforation with gray MTA, causing discoloration, of course, of the central incisor. So this is the pre-op. This is the discoloration. Look at the gingiva next to the perforation. I start the access cavity with a high-speed burr, just to remove the composite. And then with the ultrasonic tip number 3, I remove the gray MTA, working very gently, without any irrigation, and having a wonderful control of what the tip was doing inside the canal. Now I introduce a pre-curve micro opener in what I thought more to the palatal and more to the mesial, I thought maybe that's the orifice of the original canal. And then doing this, I made few debris of dentin, and then I took the air syringe with a pretty high pressure, and I started blowing air in the access cavity like this to remove the little particles of dentin. And this is when the patient said, ouch. And then I, just to make a joke, I said, lady, you shouldn't say ouch. You should say thank you, because I found your canal, and I can already tell you that your canal is open, patent, down to the foramen. And what you felt was the pressure of the air arriving to the periodontal ligament. I was not just stimulating the nerve because the pulp was dead. But so now I knew already that the pulp was necrotic, but the canal was completely patent and negotiable to the very end. So let's see now in detail the tip number 3 and its use, for instance, in the removal of a carbon fiber post. This is what I did with a high-speed diamond burr until I found in the middle of the composite these two black round material. The black material, of course, are carbon fiber posts. Now the fiber posts are straight, and they have been positioned in the straight portion of the canal, so they can be removed very safely. They can be disintegrated with an ultrasonic tip deeper and deeper in the canal, because the ultrasonic tip is straight, but also the carbon fiber post is straight. So as long as I see some black material, I keep working without any irrigation now, of course, to have a better control. I work in that material until I see the material is not there anymore, still there with some composite around. Now the composite has been removed, and now I have the gutta-percha, and so I can start my retreatment. This is another case of another carbon fiber post, round black material surrounded by composite. So I don't like to use any rotary instrument without knowing what the tip is doing, or the rotary instrument. Gates clean and drill or piezo reamer or largo, my goodness, they're very, very dangerous. But with the ultrasonic tip, knowing that the ultrasonic tip is straight, but also the carbon fiber post was straight and introduced in the straight portion of the root canal. That means that as long as I see a round black material, I can keep working on that material, disintegrate the entire material until I see that there is no more carbon fiber post, and maybe I can find the sealer or the gutta-percha. So let's see here what is going on. Still working at the maximum power, very gentle. The patient is without anesthesia. If I overheat the tooth, the patient will tell me that he's feeling something. And then I try to be more gentle. I start irrigating. I use water in order not to develop too much heat. This is the syringe. Now I see the pink gutta-percha, which means that the carbon fiber post has been completely removed. Very, very safely and pretty fast. Here's the gutta-percha. And now we can start the entire retreatment, removing the gutta-percha, negotiating, cleaning, shaving, and doing everything. Okay. The number T actually has nothing to do with the access cavity walls, but has been designed specifically to remove metal posts. Has this particular shape so that it can vibrate the post on top of it with a flat surface, or on the side with this angle, transmitting on the side vibrations mainly for the screw post. So this also has a water port for irrigation, and this is the image of the tip number 4. And let's see now what I've done so far using a diamond high-speed burr, round burr, making my access cavity through the crown, a porcelain crown, and porcelain and metal. And now with the tip number 3, I am removing the composite around the square cross-section of the screw post. Somebody can say, well, I can do exactly the same using a high-speed burr here. Yes, but if we touch the screw post with a high-speed burr, you can make it thinner and thinner, and you can break it. On the other hand, if I touch the screw post with the ultrasonic tip, I transmit vibrations, and I can improve and facilitate the removal of the screw post later. As soon as I have enough space around the square cross-section of the screw post, I will start using the tip number 4. Let's remove a little bit more composite around. Still working dry at the maximum power. And now it's time to use the tip number 4. It can be used on top of the screw post or on the side, going counterclockwise. So now I am on top, and now I am on the side. When you see that I'm going clockwise, like now, I'm actually going counterclockwise. The video is made in the real patient through the mirror. And you see that in a few seconds, the screw post is out of the canal, which means that now we can remove completely all the composite around, and we can start our retreatment. Let's see now the tip number 5. The last tip of the kit has been specifically designed for finishing the pulp chamber floor. Now, the pulp chamber floor, mainly of the lower molar, has a shape of a convexity, okay? And that convexity is very useful for us because the smooth wall of the access cavity and the convexity of the floor will automatically guide the tip of the rotary or hand instrument inside the orifice of the canal without taking the mirror to see exactly where is the orifice of the canal to introduce the instrument inside. That's why we need to preserve or to discover, if it is not visible at the very beginning, the original convexity of the floor of the pulp chamber. For this reason, this tip works on the side, having the same grooves or the same blades, but it works mainly on the tip, which is not flat but is concave, in order to find out the original convexity of the floor of the pulp chamber. This is again the drawing, the water port for irrigation, and this is the typical case. Now I want you to notice that this is the roof of the pulp chamber, and this what it seems to be the floor of the pulp chamber. But this is not the floor actually, because the floor is down here. And what we see here, this is a big calcification. It's like a big mushroom on top of the floor, which needs to be removed. So this is the roof, and this is not the floor, because the floor is down here. Okay? This is a big calcification that needs to be removed. So this is the case. He came, is a young patient, came with the symptoms of irreversible pulpitis, and because, let me go back for a second, the patient had the cracked tooth syndrome, and the crack was very close to the pulp horn. That's why she had symptoms. And now, what we see here, it is not the floor, but it's an enormous calcification that has to be removed, because underneath there, inside the calcification, could be inflamed tissue that later become necrotic tissue and bacteria. So we cannot do a root canal treatment and leaving that material in place. That's why before negotiating the canal, the pulp tissue is still there, it's still working dry without irrigation and at the maximum power. I very gently touch the calcific material until it is completely removed. And of course, I do this before negotiating and enlarging the canal, because all the debris or this big particle that we see here could fall down and block the canal from the very beginning. So let's continue to work with the tip, with the concavity of this ultrasonic tip until the calcification is completely removed, and then I see the original convexity. Irrigation to remove the debris, and this is the original convexity. Now I see these grooves that I just don't like them, and this is the reason why with the tip number 1, it's not that if I leave it there, if I leave them there, I can compromise the result of my therapy. But just for aesthetic reasons, I like to finish with a very nice, smooth convexity of the flora. And then with the tip number 1, which has a smooth tip, not aggressive, not cutting, I try to remove all the groove that I left with the tip number 5. Irrigation, and this is now the original floor with the original convexity, and now is the time to clean and shape the canal. This is the same floor, nice and smooth, after working with sodium hypochlorite and cleaning and shaping the 3 canals. So let's see now the post-operative film. This is the post-operative film. If I superimpose part of the pre-operative film, again you see that this is the roof, this is the calcification, this is the original floor. So if I leave my mouse here, okay, here is the original floor. If I go back for a second, sorry, I went too much. So this is the superimposition of the pre-op, okay, that's the calcification, and this is the original floor where I had my mouse. Okay, so this is the end of my presentation, and I hope that everything is nice and clear. In case of any doubt, please ask me, send me a message, send me an email, and I will be happy to answer to you. Okay, bye bye, and enjoy my presentation. Bye bye.